Today I'd like to talk about ECMO for cardiac patients. And first I have a disclaimer. ECMO is ECMO. Many of the issues that we're going to talk about regarding ECMO aren't really unique to cardiac patients. ECMO's been around for a while. We often think that it was invented for newborn respiratory failure, but it wasn't. That just happens to be the population that achieved the earliest and most success. Bob Bartlett is widely credited with inventing ECMO. Dr. Bartlett was one of my mentors when I was training at the University of Michigan. I had the opportunity to be one of his early ECMO fellows in the early years after his arrival in Ann Arbor from UC Irvine. And this video from a presentation he gave in Sweden a number of years ago I thought was really interesting in talking a little bit about the origin story of ECMO and pointing out the fact that ECMO actually was developed for pediatric cardiac support. At least the concept, the situation that motivated its development certainly was rooted in that, as he explains in this video.
This is the surgical staff at the Boston Children's Hospital. This is Robert E. Gross, arguably the most important surgeon of the last century. This was the very early days of cardiac surgery, and most of it was done in children, and the complicated operations for tetralogy or transposition had a very high mortality. 50% of those children died. And the residents who did all the work here in the back row looking after those patients knew that if we could just keep those children alive for a couple of days, they'd be all right. Nowadays, we recognize what we would call myocardial stun. It used to happen a lot. We didn't have a name for it, but we just knew it didn't last very long. And so I was bold enough to go to Dr. Gross and say, why don't we just keep these kids on the heart-lung machine? I mean, they've been on it for the operation. Let's use it for a few days. Well, he said, of course, that's ridiculous because the machine is lethal in about 2 hours, which it was. But why don't you work on it? So we went to work on it.
So, as that prior slide showed, Dr. Bartlett was a resident at the Brigham in the 60s. He finished training, had done some research at the NIH developing membrane lungs, and then in the early 70s was at UC Irvine. And it was in 1971, only 5 or 6 years after that story that he related, that the first successful application of ECMO for a patient was reported. It was actually at another hospital in Southern California, not Dr. Bartlett's team, and it was management of a 24-year-old who was suffering from ARDS, I believe after a motor vehicle accident. The following year, in 1972, was the first application of ECMO for pediatric cardiac procedure with a survival. It was done in a child who had undergone a mustard operation, and as Dr. Bartlett alluded to in that video clip, was suffering low cardiac output early after the procedure. As we can see from the graphic on the left, he was only on bypass for about a day and a half, and it was initiated pretty much at the time of the operation. So it was successful in achieving what Dr. Bartlett had initially thought would be a prime application for this. But it was a few years later in 1975 that the first neonatal ECMO survivor was reported, and that was a little girl named Esperanza. It was a foundling child that had been abandoned, that the nurses in the ICU, as the story goes, named Esperanza, which is Spanish for hope. And it was a little girl with persistent pulmonary hypertension or persistent fetal circulation. And we can see from the graphic again on the left, ECMO was initiated sometime late in the first day of life, so very early in life, and the child was supported on bypass for about a week. 7 days is when the off ECMO time frame is noted. In the 10 years that Dr. Bartlett was at UC Irvine, 1970 to 1980, really represents the first decade of application of ECMO to humans. And in that decade, he had experience at that institution with 72 patients. And you can see from this slide that the reason why it gained traction dealing with newborn respiratory failure was because those kids did well. 55% of the patients that they tried to support with ECMO survived, whereas only one of the 20 adults that they tried to support survived. And the results in older children was a little bit in between. And from there, things blossomed. It was a start. It was a promising start. And from really this decade that represents probably about half of the world's experience with ECMO, because very few centers really had started this type of therapy, things grew. And the ELSO registry, which was begun within a decade of Dr. Bartlett's leaving Irvine, started to accumulate the international experience with ECMO. And from its inception in the late 80s, early 90s, over the course of the next 25 years, as is depicted in this slide, nearly 60,000 patients had been supported using ECMO. And as we also can see on the slide, about half of those were newborns with respiratory failure. And as many of us have come to understand, most of those children survived ECMO. 84% newborn respiratory failure, ECMO survival, 74% survival to hospital discharge. As time has gone on, the indications have broadened to include cardiac support or ECPR, ECMO initiated during cardiopulmonary resuscitation, and expanded in terms of age groups. But still, the majority of patients in the registry are newborns. As we get into the older groups, the indications shift, certainly away from respiratory support and having a more equal distribution between respiratory and cardiac support. So when Dr. Bartlett initially developed ECMO, I remember him saying that he really hoped that ECMO would continue, or would contribute rather, to its own obsolescence, that we would use it as a tool to learn more about the problems that required this support in hopes of managing them with less risky strategies. And to some extent, that wish has been fulfilled. The development of nitric oxide for managing persistent fetal circulation and surfactant replacement has been successful in avoiding the use of ECMO in a lot of patients, and some of the development of those modalities was enabled by being able to keep some of these really sick kids alive using ECMO. But ECMO is still around. ECMO still has an important role in our armamentarium. But what's interesting is over the course of the last 25, 35 years, it really fundamentally hasn't changed that much. On the left shows a diagram from an ECMO circuit in 1975 from one of Dr. Bartlett's original monographs, and shows a fairly simple system with cervical cannulation, a venous limb going into a servoregulator system hooked up to a roller pump that then pumped blood to a membrane lung through a heat exchanger and then back to the patient. And the ECMO circuit in now the second decade of the 2000s doesn't really look a whole lot different. Yes, some of the components have been changed. The membrane lungs that we use now, such as the Quadrox lung shown here, are improvements on the original spiral round envelope membrane lungs that were originally used. They have lower resistance, better performance in oxygen and CO2 exchange. And many centers have migrated from roller pumps to centrifugal type pumps. But the fundamental organization of an ECMO circuit really hasn't changed that much. And this is a slide from a talk Dr. Bartlett gave about 10 years ago, and recognizing that while ECMO still holds an important place in our armamentarium, it still has its limitations. There's still a lot of challenges, as we all know, dealing with patients on ECMO. He summarized it works, but it's too complex. A specialist is required. Somebody needs to be sitting at the bedside to manage this. It can fail suddenly. You can have a blowout of the circuit, air entrained in the circuit, blood clots, and those failures can be not only sudden but potentially catastrophic. The system is still too thrombogenic, even with heparin-coated circuits and a lot of things like that. Anticoagulation in some form is still required. And vascular access can be difficult depending on the size of the child, depending on the way that ECMO is being applied. And a lot of smart people, and he included himself in this group, don't really understand fully the physiology. So what I want to go through in the next number of slides is my personal perspective on ECMO for cardiac patients. There's a lot of ways that ECMO is applied for different disease processes, and there's a lot of ways that patients are taken off ECMO for these different disease processes. And I'd like to just share my perspective on some of these, and it's simply one way of doing things. So first question is, when do we use ECMO? What are the indications for placing a cardiac patient on ECMO? And I want to, again, focus mostly on the cardiac patients for the rest of this talk. It's, in my mind, easy to divide the indications for ECMO into phases around the surgical repair of children's heart defects, because many times it is associated with the surgical options for managing complex cardiac disease. In some cases, it's initiated before a planned operation, often as a bridge to repair, such as a child with significant pulmonary vasospasm with transposition of the great arteries that is severely cyanotic, that can be supported on ECMO as the pulmonary resistance relaxes, and then sometimes go to the operating room to undergo an arterial switch operation. And in some situations where we're not really sure that the patient can be bridged to a successful repair, it's sometimes bridged to decision or bridged to transplant, if that's the ultimate surgical option for the anomaly or the disease process. Probably the largest group of cardiac ECMO patients are patients that are placed on ECMO intraoperatively as a bridge to recovery after undergoing some form of corrective cardiac surgery, but unable to wean successfully from cardiopulmonary bypass, either in the moment or shortly thereafter, and are supported on ECMO while the heart has more time to recover. Exactly the concept that Dr. Bartlett had as he was envisioning the development of prolonged cardiopulmonary bypass support in the first place. And then in some situations, if recovery is not expected or turns out not to be the case over a number of days of support, ECMO may be a bridge to a more durable mechanical circulatory support, a VAD device, or to transplantation. And then sometimes it's employed in the postoperative period, also as a bridge to recovery if it's in the early postoperative period, but more often, particularly in the later postoperative period, as a bridge to a more durable circulatory support or transplantation. And so now this is data from the ELSO registry again for ECMO support for cardiac failure. Depending on the age, the specific cardiac indications can be quite different. In the newborn period, as one might expect, the vast majority of children supported on ECMO are due to problems with congenital heart defects. And it may be preoperative, it may be postoperatively or intraoperatively. As we get into the older age group, the mix changes. The younger patients still are predominantly represented by congenital defects, but the older patients, then we start to have more representation with myocarditis or other problems, cardiogenic shock potentially related to an overwhelming infection or something like that. Just from a fundamental physiologic standpoint, what are the indications for ECMO? Why do we place a patient on ECMO? Well, ECMO basically is a simplified heart-lung machine, so it supplies both cardiac and pulmonary support, potentially both, depending on how the setup is. And so we're supporting either perfusion or oxygenation. And then those can be subcategorized further. So on the perfusion side, the perfusion difficulties that we need to support may be related to pump dysfunction or potentially related to dysrhythmias. And on the pump dysfunction side, it may be related to injury to the heart, either by viral myocarditis or surgical trauma or inefficiency of the pump. Again, possibly due to chronic overwork or acute processes. On the oxygenation side, we may have problems with oxygenation because of pulmonary parenchymal dysfunction or due to problems related to pulmonary blood flow. And the pulmonary blood flow problems may be related to anatomy. A child that has a narrowing or acutely thrombosis, a systemic to pulmonary shunt would be an example. Or the pulmonary blood flow issue may be related to resistance. That's the classic example of babies with persistent fetal circulation or having problems with persistent, prolonged elevation of the pulmonary resistance vessels. Whatever the underlying problem is, it's important to try to identify because largely the success of ECMO depends on supporting a problem that you think is reversible with either rest or intervention in about a 5 to 10 day span. And while certainly patients have been supported on ECMO for longer periods of time, we know that the incidence of complications starts to rise over time. But it's important to understand the underlying reason for ECMO support in the first place, to have a sense for how you're going to deal with it, whether you're simply relying on rest and you expect that 5 or 10 days of rest is going to be sufficient, or some intervention can be carried out in that time frame to ultimately get them successfully off ECMO in that week or two time frame. This graph is from a study that was published in 2011 looking at a population of ECMO patients, 773 of them, that were on ECMO as a bridge to transplant. All patients were listed for transplantation, and it looked at outcomes. And what I hope to use this study for is an illustration about why we say it's important that the process is reversible or otherwise manageable in a 5 to 10 day window. And so what we see here of these 773 patients who were listed for transplant and on ECMO, the green curve shows kind of a steady decline of the number of patients alive and still on ECMO. And this is over a time frame of about 3 months. And the incidence of mortality on ECMO gets up to about a third of the patients. The incidence of patients transplanted gets up to about 40%. And a small percentage of patients actually recover, despite the fact that they were listed for transplant, show enough improvement to be able to be separated from bypass without undergoing transplantation. So from this we see in a 90-day time frame, only about 40% of the patients were actually transplanted when that was the intention to treat when they went on ECMO. What's interesting from this study was that they found that, overall, and it carried out a little bit further than what this graph shows, 45% of the patients were transplanted. But beyond that, about a third of the patients that were transplanted did not survive to hospital discharge. And so what they looked into further was the reasons or things that predicted post-transplant mortality. And what they found was the patients with the congenital heart defect or kidney failure, ECMO duration of greater than 2 weeks, and initiation of ECMO as a bridge to recovery initially were all associated with a higher post-transplant mortality rate. So that, again, one of those 4 factors that was identified as a predictor of post-transplant mortality, even if you were successfully bridged to transplant, were those children that had been supported on ECMO for more than 2 weeks. So again, it sort of drills down that fact that even if you can keep somebody stable on ECMO for that long a period of time, the consequence of being on ECMO is going to translate into worse outcomes, or at least is associated with that. And so in the conclusion, in the conclusion of this paper, the author stated that although ECMO is effective for short-term circulatory support, it is not reliable for the long-term circulatory support necessary for children awaiting heart transplant. Fewer than half the patients bridged with ECMO survive to hospital discharge. More effective modalities for chronic circulatory support in children are urgently needed. Again, this was 2011. This study was actually used as the control arm for the Berlin Heart Trial, which was trying to identify a better, more durable circulatory support option for children. And since we've had a few other options have hit the table, so that some are early trials, some have been application of adult devices to larger children, but we're still in a situation where we don't have ideal mechanical circulatory support for the very smallest children, and ECMO isn't a good long-term solution for that problem. So we've talked about why we put kids on ECMO. We talk about now how we put them on ECMO. So how do we connect to support? There's a number of ways that people can be attached to an ECMO machine. We can divide things either as transthoracic versus peripheral. The cannulas that we use vary in size and numbers. We have different options, whether we're going directly into the heart through the chest or using peripheral access. Obviously, peripheral access is going to generally rely on only smaller cannulas and sometimes limited numbers. With transthoracic cannulation, sometimes you can get a lot better flow with a single cannula placed directly into the atrium, for example, for a venous cannula. There are also important anatomic considerations when we think about how we're going to support a cardiac patient on ECMO. Some patients that are on cardiac support have normal cardiac anatomy, but a lot don't. And particularly patients that are in various places on the pathway of single ventricle reconstruction strategies. The shunted single ventricle, a child with a bidirectional glen, or a child having completed a Fontan reconstruction, are all very different in the challenges they present in terms of connection to ECMO support. And this diagram represents a pretty typical cannulation strategy for patients with normal cardiac anatomy. Usually that's done through the neck. It can be done percutaneously or via cut down, with the arterial cannula inserted into the common carotid artery and threaded down toward the aorta, but ideally not into the aorta, and certainly not so far as down to the area of the aortic valve. And then the venous cannula introduced via the internal jugular vein and advanced into the atrium. And the venous cannulas placed in this method have multiple side holes as well as the end holes, so that they're holes that are dispersed throughout the span of the atrium. With a patient with this shunted single ventricle circulation, it's important to look at what you're trying to support. It's important to remember that if a child is supported with ECMO and has a BT shunt, that BT shunt is coming off the aorta and then is thus reliant on the ECMO support for its flow as well if the native heart isn't supplying adequate cardiac output. Whereas a sono shunt, a right ventricle to pulmonary shunt, does not rely on blood flow from the aorta and thus is not supplied from an ECMO support circuit. With the patient having undergone a Glenn circulation, you have to ask whether you cannulate the atrium, the cavo-pulmonary circuit, or both, and it partly depends on the indications for support and what you're trying to accomplish. Is it primarily cardiac support? Is it primarily pulmonary support? Because the choice of cannulation strategy is largely influenced by whether you're supporting the heart, the lungs, or both. And then finally, with a Fontan circulation, nowadays we often do extra cardiac Fontan completions with conduits. Many of those can actually be successfully cannulated through cervical approach with directing the cannula down into the Fontan pathway. Although with that pathway being smaller than a native atrium, that may somewhat hamper the flow into the cannula. The cannula can potentially get up against the walls a little more easily. But what a Gore-Tex conduit does often prevent is the typical transthoracic cannulation that you would expect, being able to cannulate a systemic venous chamber. When we're managing support with some of these kids with unusual cardiac anatomy, it's always important to remember that cannulating the right atrium and putting blood into the aorta may bypass a lot of anatomy, and that anatomy has to be taken into consideration. Again, it may be the source of pulmonary blood flow, or it may include the pulmonary blood flow and has to be taken into account. ECMO is a closed system that does not empty the heart. In the operating room, the conventional cardiopulmonary bypass systems that we use does empty the heart. We have an open system. Blood is displaced from the patient's blood space to the reservoir in the cardiopulmonary bypass, and we can maintain normal cardiac output with an empty venous side of the heart, but that's not the case with ECMO. The ECMO systems pump back whatever they get. It's a closed system, and the volume in the patient stays essentially normal. It doesn't empty the heart. It may empty certain chambers, it may decompress certain chambers, but it doesn't empty the whole venous space the way conventional cardiopulmonary bypass does. Not all systemic venous return may go to the ECMO circuit, depending on the anatomy. Again, if we have a patient with a Glenn, we choose to only cannulate the superior caval circulation. The inferior vena caval blood flow is not coming back to the ECMO circuit. And it's important, again, to remember, and especially in these shunted patients, that the ECMO circuit may be perfusing the body and the lungs, either because of surgical or natural shunts, and it's important to recognize that, because for cardiac support, if we're trying to support cardiac output, systemic perfusion, it's important to recognize that the ECMO circuit may also be supporting pulmonary perfusion, and we can't assume that what we may calculate as a normal cardiac index delivered by the pump is adequate for systemic perfusion support of the patient, when it's also having to support the pulmonary circulation as well. Taking blood out of the right atrium and putting it into the aorta on ECMO doesn't completely evacuate the right side of the heart. There is going to be blood going past the cannula out into the lungs, returning to the left side of the heart. And in cases where the left ventricle is severely compromised, the left ventricle still may need to eject a reasonable amount of blood. And if it's failing terribly, that may lead to left ventricular dilatation, elevations in left atrial pressure, and pulmonary edema. So in patients, particularly those patients with acute myocarditis or similar type of cardiomyopathies, just conventional ECMO cannulation may result in significant pulmonary edema if the native heart isn't capable of pumping even the small amount of blood that it's asked to. And so continuation on inotropes may be important, or making sure we do decompress the left atrium either by fenestrating the atrial septum or adding a left atrial cannula must be considered in some cases. And again, what I've mentioned before, the ECMO circuit may be perfusing the body and the lungs, so it's important to understand that when you're trying to make estimates of how much support you're getting. We always want to monitor the ultimate result of adequate perfusion of the tissues, but it's important to recognize that the output from the ECMO circuit is not necessarily equivalent with systemic perfusion. It doesn't include the native cardiac output, and it doesn't necessarily account for pulmonary blood flow, which may be coming off the ECMO circuit. Ultimately, in most of these cases, our goal is to rest the heart or the lungs, but we still may need to have them do some work, especially the heart. It's pretty unusual that a typical ECMO circuit can support a full normal cardiac index. Usually, in most of these cases, the heart has to have some function so that the combined output of the native heart and the ECMO circuit can supply the tissue with adequate perfusion. We generally want to choose ventilator settings that are going to avoid barotrauma or volume trauma. That's very important in patients who are on for respiratory support that may have parenchymal lung problems that we don't want to exacerbate. And it's ideal to be able to expand the lungs to FRC, functional residual capacity, because that minimizes the resistance through the pulmonary vascular bed. But again, in many of these cases where we do have to rely on the heart to continue to supply some of the cardiac output, maintenance of inotropes is often something that you need to consider. We don't want to be whipping a sick ventricle with high doses of inotropes, but inotropes in moderation to augment the limited cardiac output that's there is often beneficial in supplying an extra 10 or 20% of cardiac output that can be crucial in maintaining adequate oxygen delivery to the tissues. And then again, as I mentioned before, if the left atrium is very hypertensive because the left ventricle is failing miserably, and that starts to result in pulmonary edema, which is then now a second disease on top of the cardiac failure, consideration of left atrial decompression has to be entertained. And so how do we assess the adequacy of support? Again, it's all about oxygen delivery to the tissues, and quite often we'll use monitors of oxygen content in various parts of the circulation to assess the adequacy of oxygen delivery. The CDI monitors, which are inline monitors, can be hooked up to the arterial or venous limb of an ECMO circuit and give continuous readout of a number of parameters, including PO2 and PCO2. NIRS monitoring, just like it's used for patients that aren't on ECMO, it's used commonly in the cardiac ICU as a trend monitor for mixed venous saturation, which then can be used as a trend monitor for cardiac output. These monitors are crucial in patients on ECMO for making sure that we are ultimately achieving our fundamental goal of adequate oxygen delivery to the tissues. These monitors of mixed venous saturation are important because, again, they can give us a clue to the adequacy of cardiac output. I love this analogy of oxygen economics, the concept of supply and demand, where oxygen is loaded into the blood, typically in the lungs, or in a case on a child supported on ECMO, in the lungs and in an ECMO circuit. And it's consumed in the tissues, and the delivery system is dependent on three factors: hemoglobin concentration, oxygen saturation, and cardiac output. I love the train analogy because, again, the number of box cars is analogous to the hemoglobin concentration. What's the carrying capacity of our process. The oxygen saturation is how full are those boxcars, and the cardiac output is how fast is the train running. But in cases of patients on ECMO, it's always, again, important to remember that cardiac output is the sum of what the ECMO circuit's doing plus what the patient's doing. And it's very rare that ECMO can supply a full cardiac output for a prolonged period of time. The patient is almost always supplying some degree of native cardiac output, and often that's crucial in maintaining adequacy of oxygen delivery. And so this shows an example of a 10-kilogram child with normal physiology, oxygen saturation, normal 95%, normal hemoglobin level 13 grams per deciliter, and a cardiac index of 3 liters per minute per meter squared. We can calculate the oxygen content or oxygen delivery based using those numbers. We know that oxygen consumption is roughly 150 mils per minute per meter squared. And so the mixed venous saturation is a reflection of how much oxygen has been unloaded in the tissues. And in a normal situation with normal oxygen content and normal cardiac output, mixed venous saturation tends to run about 70%. So we really only unload about 25 to 35% of the oxygen that's delivered to the tissues. In a low cardiac output state where the first two parameters are maintained the same, still fully saturated, still a normal hemoglobin level, but half the cardiac index, still have the same number of boxcars, they're all full leaving the station, but the train's moving more slowly. So as it moves more slowly through the tissue, more oxygen is taken off of each boxcar, so when the train returns to the station, the mixed venous saturation is substantially lower. And so this shows how mixed venous saturation can be a reflection of cardiac output. And we know that in most situations in normal physiology, cardiac output or normal oxygen delivery is actually exceeding what oxygen utilization is by a factor of about 4 or 5 to 1. If we have blood that leaves the heart at 100% oxygen saturation and returns to the systemic venous side with 75% saturation, that means we've only removed 25%. So we've got an oxygen delivery of excess of 4 times luxurious delivery. And if you elevate oxygen delivery, it isn't really going to change oxygen consumption. Oxygen consumption is dependent on the tissue needs, and over a range of oxygen delivery, as is seen on the x-axis here, oxygen consumption doesn't really change as you drop delivery until you reach a critical point. And then oxygen consumption does become supply dependent. That once you hit a critical point where the body can't remove any more oxygen because it's just not being delivered with enough excess, we start to go into oxygen debt. We start to see lactic acidosis, a base deficit. And that inflection point is at about 2 to 1. So when oxygen delivery is only about twice what oxygen consumption is. And so that helps us get a sense for how to interpret mixed venous saturation data when the AVO2 difference, the difference between the arterial and the mixed venous saturation, is about half of what the arterial oxygen saturation is. We know we're getting into a critical area where we may start running into inadequate oxygen delivery to meet the patient's tissue needs. And again, we can assess the adequacy of that support and mixed venous saturation by looking at the NIRS monitor, which is a tissue oxygen saturation. So that's sort of real in the patient physiology mixed venous saturation. But the CDI can measure that on the ECMO circuit. And as long as the venous return to the ECMO circuit is truly mixed venous blood, then that CDI measurement can be a good reflection of cardiac output. But it's important to understand what you're sampling, and particularly important in patients with congenital heart diseases, because the venous cannula may be positioned in a location where, yes, it drains predominantly systemic venous blood that needs to be oxygenated, but in patients with intracardiac shunts, atrial septal defects, things like that, pulmonary venous blood is going to go to the venous cannula as well. And so blood that's been oxygenated in the lungs, and in cardiac support, the lungs are usually pretty healthy, so any blood that's getting out there is going to be adequately oxygenated. Then that contaminates the mixed venous blood, and so that the venous saturation on an ECMO circuit may not truly represent mixed venous saturation or systemic mixed venous saturation. It may be a mixture of pulmonary vein and systemic venous blood. So you have to always take that with a grain of salt. You have to know where you're sampling to understand the reliability of your venous saturation data. And then obviously we also want to monitor end organ function. We're going to watch renal function. We're going to look at liver function, CNS function, GI function, and watch out for necrotizing enterocolitis. We're going to monitor various metabolic parameters, lactate levels, base deficits, anion gaps. One thing that's sometimes interesting to look at is the difference between the PO2 between a sample from the ECMO arterial circuit and the patient's arterial circuit. Because again, most patients are going to have some blood flow that doesn't go out the ECMO circuit but goes on through the normal circulation. So the patient's arterial blood is a combination of blood that's supplied from the ECMO circuit, which should be very well oxygenated, and blood that's supplied by the patient's own left ventricle, which will be oxygenated in a typical way that lungs oxygenate things, and the PO2 usually would be lower, depending on what ventilator settings and what supplemental oxygen they're on. So most times the ECMO circuit has a very high PO2 coming directly off the membrane lung, and then when you look at the patient's arterial PO2, it's somewhat lower because pulmonary venous blood is not going to be showing a PO2 in the many hundreds. It's usually going to be right around 100. It's a worrisome sign when we see that the ECMO arterial PO2 starts to equal the patient's arterial PO2, or the other way around. It's really when the patient's arterial PO2 comes up to the levels that we see coming off the ECMO circuit. It sounds a little counterintuitive that we'd be concerned by a higher arterial PO2 in the patient's own blood, but it's a reflection of the fact that the patient's own heart is not contributing significantly to cardiac output. And it's a red flag in my mind that now you really are relying on your ECMO flow for the vast majority of the cardiac output. And you've got to be darn sure that your ECMO circuit can deliver that level of flow. And with most circuits, largely because of limitations of flow imposed by the venous cannula, it's really hard to get flows up to a cardiac index upwards of 3.5 liters per minute per meter squared, which we'd normally consider to be a full cardiac output or full cardiac index. So, as I've alluded to in the past, and as we all know from any experience we've had taking care of patients on ECMO, dealing with ECMO is also a part and parcel with dealing with the potential complications on ECMO. And this table, also from the ELSO registry, lists some of the major complications that are seen managing patients with ECMO for cardiac support. And the ones I want to really focus on is surgical site bleeding. Many of these patients, as we said earlier, are perioperative patients. They have undergone major operations, and sometimes if they can't separate from the cardiopulmonary bypass circuit, they haven't had an opportunity to have the heparinization that is pretty aggressive in the operating room reversed at the end of the procedure with protamine, as we would normally do. And so they may have a lot of surgical site bleeding going on in addition to the other kinds of bleeding problems we see on patients supported with ECMO. And so how do we get patients off ECMO? In the best case scenario, we've seen recovery. We've seen things get better to the point where we don't think we need the ECMO anymore. And there's a lot of different strategies that different people employ for getting patients off ECMO. Some folks prefer a slow wean, others prefer a fast wean or trials off, sort of abruptly taking somebody fully off ECMO for a period of time and see how they do. And there are pros and cons with either approach, and what's best for an individual patient may be different from another patient, so depending on their specific circumstances. So some would argue that a slow wean, gradually dialing down the flow, is a safer way of doing things. You're more gradually allowing the patient's own body, whether it be heart or lungs or both, to show that they're able to do a little bit more work on their own. It has the advantage that coming down slowly maintains more circuit flow for a period of time, so that may be associated with less risk of thrombus formation within the circuit. But it may not reflect the full degree of recovery, because if you're still on some support, you may really not know for sure whether you're able to completely separate. And particularly if we're dealing with lung support, it doesn't take a lot of ECMO flow to fully oxygenate blood to maintain adequate oxygen saturations. Trials off, on the other hand, can be used as a means to track progress on a daily basis. We could sort of do daily trials off, maybe even starting when we're at a point where we don't have a high expectation that the patient's ready to completely separate from bypass, but we want to get a baseline. And then if we trial off again tomorrow or the next day and we see the patient lasts a little bit longer, does a little bit better, we've got some sense that there's improvement going on. Because again, once the days start to mount that somebody's been on support, we have to start thinking about alternatives if recovery isn't apparent. And lack of progress on daily trials off can be a red flag that you need to start thinking earlier about conversion to a more durable mechanical support, listing for transplantation, or other strategies. And so that addresses sort of that trajectory, allows planning for future options. And the disadvantage of trials off often is that you need to escalate support each time you do a trial off. Most patients are on rest settings, whether that's rest doses of inotropes or rest settings on the ventilator, and each time you do a trial off, we've got to crank those things up to the support we would expect the patient would need if they're not on bypass anymore. And that can be sometimes cumbersome and difficult to accomplish logistically. But it's important to remember that even a little bit of support can make a big difference. And so in many cases with cardiac support, I'm a fan of doing trials off. And it's fine to wean down slowly if there's advantages in that for the patient. But ultimately, no matter what your weaning strategy is overall, the patient needs to have a trial off for a period of time to prove that they really are ready to go without any flow. And we certainly see it often enough in the operating room that even just a little bit of flow from the pump can make all the difference in the world, and things just fall apart after you remove that last little bit of support. And we have to recognize that when we're coming off of ECMO, we're not totally coming off of support. We're really not, you aren't really riding on your own until you lose those training wheels, but we also will be maintaining support of the patient with inotropes and ventilator settings, and the vigilance of the rest of the support team at their side to address shifts and changes in their stability and react to those changes proactively. Some unique situations allow different weaning strategies. Sometimes we can wean the oxygenator alone, isolated oxygenator weaning. We can maintain flows, but wean the gas from the oxygenator, so turn the oxygen flow off in the oxygenator so that we're not using the membrane lung. That can be done in cases where a patient's on veno-venous ECMO support, where you just don't want to change the hemodynamics at all, you just want to change the oxygenation. Well, veno-venous ECMO probably doesn't change the hemodynamics much, but you can at least maintain a reasonably good flow through the circuit to avoid clots while you assess how much oxygenation the patient needs. But particularly for some cardiac situations, we have that as an option too. A patient that has a Blalock-Taussig shunt where the ECMO circuit is supporting pulmonary blood flow, turning down the oxygenator, they still should have fairly normal pulmonary blood flow, and the ECMO circuit helps to support a normal cardiac output. It can sometimes be very instructive in identifying the fact that, yeah, our lungs are working okay as long as we get decent blood flow to the lungs. Now is the patient ready to wean from support from a cardiac standpoint. And similarly with a bidirectional Glenn situation, if you're just draining the heart and not draining the cavopulmonary circulation, you should have pretty normal pulmonary blood flow for the Glenn circulation, and you should be able to remove the oxygen from the circuit and just basically convert it to a standard VAD circuit. The common denominator with these things clearly is that pulmonary blood flow is maintained during ECMO support with any of these modalities, so that you should be able to wean off the oxygen from the ECMO circuit and see what the impact is on overall oxygenation based on purely the patient's own lungs supplying the oxygen to the blood. And this can sometimes allow for isolated assessment of native pulmonary gas exchange without altering cardiac output and without the risk of cannula thrombosis. And so in most of these situations, we're trying to migrate from a lot of support to a little support to some backup support to ultimately the patient flying high on their own. And then just to wrap things up, I just wanted to conclude with some remarks that Dr. Bartlett made at a TED Talk that he gave a number of years ago, reflecting back on the development of ECMO and its use in our toolbox.
Someone earlier was talking about saving lives. We never save lives, we only prolong them. But if you can prolong the life of the baby for 70 years, that's worth doing.